Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning.
Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and I'm delighted to be joined by Dr. Angelika Razzaque today. Dr. Razzaque is a GP and GP trainer in South East London, UK, and works at King's College Hospital in dermatology. Welcome, Angelika. Can you tell us a little bit about yourself?
I'm a GP in Southeast London. I used to be a trainer. My concentration has been now more on kind of doing dermatology and improving dermatology services for patients here in Southeast London. So I'm working at King's College Hospital in the 2-week wait skin cancer clinic, and I also run a community dermatology service in Lewisham. So been very, very busy with dermatology, and I'm a member of the Primary Care Dermatology Society Executive Committee as well for many, many years now. And I have been lecturing nationally. I've done a lot of webinars, publications. So I've been really, really trying to drive improvement of dermatology service provisions across the board.
That's brilliant, Angelika. So as a GP who works in dermatology, what are some of the most frequent acute skin conditions that you would be seeing?
I think we know now that probably a quarter of our consultations in general practice are skin related, and these could be the most common and probably inflammatory conditions such as eczema and psoriasis. But there might be others like inflammation that GPs sometimes recognize or sometimes have difficulties identifying. Of course, we see a lot of infections, pityriasis vesicular, pityriasis rosea, tinea, impetigo, viral exanthems, and then of course chickenpox, shingles are always or seasonally around and pose sometimes a real challenge for patients as well as for clinicians. And of course we do see a lot of lesions. That is probably next to eczema one of the most biggest presentations in general practice, benign and malignant lesions.
You mentioned seasonally. So would you say there are certain acute skin conditions that are more prevalent during particular times of the year or in specific groups of people?
Yes, definitely. I mean, we see now in the summer months probably more pityriasis vesicular because patients are wearing sleeveless tops or are topless, and the skin discoloration with pityriasis vesicular is more visible during the summer months. We also see more of polymorphic light eruption, so a reaction to the sun and to sunburn in young adults, and also the juvenile spring eruption in children where mostly the rims of the ear is affected. Chilblains in winter, or as we would in lay terms call them frostbites. And then I would say kind of there might be also with seasonal respiratory and other viruses, more viral exanthems being diagnosed in primary care as well.
And what should GPs be alert to make sure that they don't miss any potential serious causes of acute skin problems in a child? I'm thinking of things like Stevens-Johnson syndrome.
TNS and SJS, or toxic epidermal necrotic syndrome, necrolysis syndrome, and Stevens-Johnson syndrome are probably less common in children, but I would generally say any unwell child with high fever, being listless, not feeding, not taking in adequate amounts of fluids. So where there is multi-system involvement and where we're really concerned and they have a widespread skin disease, being it due to a condition like Kawasaki syndrome or staphylococcal scalded skin syndrome, or epidermolysis or erythema multiforme. These can all be conditions that make children really, really unwell. They can be medication related, they can be related to viruses, and we should remember that if the skin is widely inflamed, the functions of the skin, like thermoregulation and kind of reducing transepidermal water loss, are hugely compromised. So these children are really at risk of going into shock and requiring urgent medical attention. So I would have a very low threshold to refer a sick child that has widespread disease, or any child with very widespread skin disease.
Thank you, Angelika. You mentioned impetigo earlier. Can you walk us through a typical presentation of impetigo?
Impetigo will usually manifest with redness, kind of slight vesiculation, or a small blistering of the skin. The exudate usually dries on the skin and causes these honey yellow crusts that we then see. It's mostly face, but it could happen anywhere on the body. It's highly contagious. It's caused by Staphylococcus aureus, and it usually requires antiseptic or antibiotic treatments. If it's very, very widespread, then it should actually have systemic antibiotics or oral antibiotics. If it's very localized, just around the nose or around the mouth, then this is now part of the pharmacy first scheme, and patients or parents can present in pharmacies and will be issued with appropriate treatments such as fusidine cream or something like crystoside cream as well.
Are there any acute skin conditions for which management advice has changed recently? For example, there's been any new national guidance for this?
Yeah, continuously there are kind of updates on guidance, but mostly this is kind of secondary care based in terms of new medications, new biologics being approved for management of more severe skin condition. For general practice, we haven't had any recent updates other than probably the update on scabies, which has been published by the British Association of Dermatologists and the British Society of Pediatric and Adolescents Dermatology. And that is basically based on the outbreaks of scabies that we've seen sort of post-COVID. So the management of scabies needed to be adjusted for that reason, as well as that we've seen more resistance to topical treatments. So the new guidance now incorporates using oral medication, so ivermectin based on the body weight, even including for children from 15 that have a weight of 15 kilograms onwards. So that has given us a better kind of understanding how to manage, as well as kind of has given us a bigger scope of managing scabies in the community.
Moving on to acute contact dermatitis, I would imagine that's something you see quite often in primary care. How does it get described typically by a patient, and how can GPs try to identify the cause or the irritant of acute contact dermatitis?
It is often very, very difficult, and patients probably have experienced that being in contact with a certain substance, which could be anything, that just gives them a rush somewhere on the body, often actually hands, because that's where we are closely in contact with many, many substances. A typical presentation would be maybe a person with eyelid eczema that is a new encounter that has never happened before. This patient, for example, wears nail varnish. So this is a very common culprit and probably underdiagnosed. So I would always kind of ask my patients when they come with eyelid eczema, have you used any different products? Have you changed anything? Are you wearing any nail varnish at any times? Because that can cause contact allergic dermatitis. Of course, we have also contact irritant dermatitis and many things that are not causing a typical allergic response or a kind of immune modulated response, but just a general kind of irritation on the skin. We probably see quite often nickel allergies nose, on ears from jewelry, or typically around the umbilicus with jeans, denim buttons. Sometimes we see people responding to food preparation, and garlic can be quite a culprit to cause index finger and thumb irritant dermatitis. So in any case, if we are concerned, it is really good getting our patients to keep a diary of what happens to certain exposures and then present again, because sometimes we do need to refer to allergy clinic for patch testing.
That's very interesting. Nail varnish
Yes.
and eyelid eczema, you would have thought that it would affect your fingers rather than your eyelids. That's a new one for me.
The skin of the eyelids is so thin that it is just more kind of sensitive towards any external toxins or irritants and allergens. Actually, that's why we see that.
Yeah, that's really interesting. And what would be your advice for initial management of contact dermatitis?
Well, if we have identified a culprit, we would obviously try to avoid the irritant or the allergen. That applies even to topical moisturizers, emollients, where patients have prescribed emollients or treatments and they get irritation to their skin. It would usually be managed with topical steroids or topical calcineurin inhibitors. I usually give soap substitutes to kind of avoid further aggravation of the skin, and emollients to kind of moisturize and reset skin barrier function. If we strongly suggest an allergic contact dermatitis, then, as I said, the patient should be referred to have skin prick testing or patch testing performed in secondary care.
Topical steroid withdrawal, this is another subject that I've been thinking about before. That can be really distressing. So, what are some key features that might make you suspect topical steroid withdrawal?
BAD is currently really looking into this because we've seen more and more patients attending, not just in primary care, but also in secondary care. It's a huge social media driven development where people that even have used topical steroids just once or twice think that they may have topical steroid syndrome. We as clinicians would say that it definitely is an entity. What the clinical criteria are is still a little bit unclear, and the BAD in a work group is currently establishing guidance so that we are very, very clear how to identify patients with topical steroid withdrawal. But the general consensus is that it is a phenomenon that happens after long-term use of very potent or even super potent topical steroids. So that means a daily usage for months or even years, and then abruptly stopping the steroid, and then having a rebound effect or a huge flare that makes people quite unwell as well at the same time from the withdrawal of steroids. As I said, it's still a work in progress, but I think we can reassure our patients that have used topical steroids for a short period of time to get their condition under control. If it then relapses, that does not necessarily mean it's a topical steroid withdrawal, particularly not if we've weaned off gradually. So we've used a topical steroid daily, and then we reduce it to every other day, and then we use it twice weekly and see whether symptoms are really settled. And if they're settled, we can stop completely. If they are not, we start again. If that is a common kind of scenario that patients need to go through, then they need to see their GP again to see whether alternative treatment options, either a more potent steroid or an alternative like calcineurin inhibitors, are necessary.
You're saying that there are more people that are becoming aware of it, and where do you think that increased awareness is coming from? And even people who aren't using it long term think that they have topical steroid withdrawal. So, where is this increased awareness coming from?
As I mentioned earlier already, social media has got a huge influence on this, and the advice patients get from social media sources that are not evidence-based, that are often individual people that may have suffered a chronic skin condition and have had their own experience and have made their own assumptions about what it is they've been going through. The power of social media and being drawn towards solutions that are leading to complete withdrawal, sometimes even withdrawal of moisturizing the skin and just leaving it in its kind of hugely inflamed state, can be very, very, very distressing. It can be very dangerous even, because as I said earlier on as well, our skin has got a lot of other functions, like temperature regulation. It's a barrier for any kind of getting infections or allergies. So it is hugely important that we actually treat our skin and not leave to not being managed at all. We are trying to pick this up. We're trying to refer to places where there are dedicated clinics. Here in London, for example, at the Royal London, Professor Anthony Bewley has got a special clinic, and he's got a cohort of about 100 patients now with topical steroid withdrawal syndrome, and trying to manage that in a more holistic approach, including psychology and clinician together to manage patients' beliefs and manage their problems that are real, because their skin is still a problem and the underlying skin disease needs to be managed. But we also need to acknowledge that patients have problems with the therapies that they've been suggested and have been having access to. So they might not have been the right ones, and they would have been better off on alternatives.
That's interesting that you say, in addition to the medication, you also need to give it a more holistic management, which is
Yes.
educating the patient. And it shouldn't be like a complete withdrawal from everything as well, without actually treating the inflammation. Thinking about hives now, what steps would you take to assess a patient presenting with sudden onset, widespread hives?
So hives or wheals, sort of spontaneous eruption of the skin, redness, swelling, and itching, we refer to as urticaria in medical terms, and the most common probably is the spontaneous or unprovoked urticaria, where and 50% don't find a trigger. The remaining 50% or the other 50%, it's probably even a viral infection or bacterial infection, maybe stress. So there could be various triggers that have caused that. So it's always good trying to identify whether the patient has some sort of idea what could have triggered this. It is very, very common. And 20% of people in their lifetime will have experienced it or will experience urticaria. It presents acutely, and we talk about acute urticaria when it lasts 6 weeks, and anything past 6 weeks. And sadly, a percentage of patients with urticaria will have chronic urticaria, which can last up to years. So this is something that is very, very easily managed in primary care. We are giving antihistamines, and we start off with the non-sedating antihistamines once a day. We increase it to twice daily, and if that hasn't stopped hives from occurring, we will increase it to 2 tablets twice a day. That is, of course, outside the product license of all antihistamines, but is very much in line with current guidelines, the BAD guidelines, European guidelines. So we all across the board give up to 4 times the licensed dose. And that sufficiently, in most patients, manages their symptoms. The key is that they keep on taking it, and if they've had a period of 4 to 6 weeks without any hives, then they can try without the antihistamine. If the hives recur, they restart, and then every 6 weeks or so try to stop and see whether their urticaria has actually resolved. Should this not help, then there is some recommendation to add montelukast, 10 milligram once daily. And if that doesn't help, then we would refer to secondary care for consideration of other management options.
Now, I'm thinking about the severe skin reactions, the acute reactions that patients can have in response to a drug. So,
Yeah.
what is the role of primary care in managing and reporting these serious adverse events?
If we have a patient with a serious reactions, TNS or SJS, definitely our role would be identifying a culprit, although that may sometimes be very, very a long time. I remember from my early days in primary care as a GP and going on home visit for patients with acute rushes, and they were all introduced by carbamazepine. So these patients had been recently started on an anticonvulsant medication. The advice is stop the drug immediately, don't take any further, and refer to secondary care. So that is what we really, really should be doing in primary care, picking up the phone, speaking to dermatology registrar or consultant on call, and getting them to be seen urgently, because they can become very, very quickly very unwell.
How would you differentiate between a skin condition that's more serious and that's less serious? You said you saw somebody with hives or with rashes, and how would you make that distinction?
Yeah, it is sometimes very, very, very tricky, actually. I mean, for hives, I would say the typical hive that we would class a symptom of urticaria is the hive that resolves within 24 hours. Okay, so that spontaneously resolves. It just comes up somewhere else, but the individual hives do resolve within 24 hours and don't leave any marks on the skin. If patients have a hive that lasts for more than 24 hours, and if it eventually resolves, leaves residual kind of redness or purplish coloration on the skin, then I would think this might even be urticarial vasculitis, and that should definitely be seen in secondary care. So anything, I would say, where we in primary care are not quite sure what it is and whether it is something that needs urgent attention, advice and guidance with photographs, or picking up the phone and speaking to the on-call dermatologist is always advisable, because sometimes it is very, very difficult to judge. We have cases of psoriasis, eczema that don't respond to medication. They never kind of have clear skin. And that could be because it isn't eczema, it isn't psoriasis, it is actually a condition like mycosis fungoides, a T-cell lymphoma of the skin. So it's always kind of being this mindful and reviewing patients and making sure that the treatments are working. And if they are not working, then we are at the end of our treatment options in primary care and we need secondary care input. So it is then very, very important that we have a second opinion.
What advice would you like to give to a GP who's listening to this episode that you yourself would think is really useful for your own practice?
What I often find is that we see a lot in primary care. And given that quite a lot are skin infections, I would say, please, please, please always do a swab. If the patient says, I always get this kind of infected rush, like impetigo, do swabs, send off for pathology, microbiology, and give the patient history, say it is recurrent, you're worried, and if there is MRSA positive on the swabs, please also do check for PVL or Panton Valentine leukocidine, which is kind of a special Staph aureus strain that can be quite resistant to usual antibiotics and just partially responds, but can be very, very recurrent. So it is important that that gets diagnosed, because it needs just complete different antibiotics than our usual Staph aureus receptive flucloxacillin. And mycology pathology, the number of patients I do see with rushes that have been perceived as a fungal infection, but patients never have had a mycology, so a skin brushing, to be sent to the pathology lab and have it investigated, and prescribe soap substitutes and emollients, and prescribe enough. The recommendations are 250 to 500 grams for a child for a twice daily application. For an adult, it's 500 grams for twice daily applications. And sometimes patients need more than this. So that's where we often fall a little bit short in primary care, that we're just not giving enough emollients for our patients, and we're not advising them to stop their simple soap and their natural soaps. They have to use either a soap substitute or use the emollient as a soap substitute.
And finally, Angelika, can you please tell me about a patient that you've learned from recently?
In my skin cancer clinic, I had a patient that was referred with query, is this skin cancer? Because he was treated for very widespread skin condition that was macular, plaque-like, almost in places raised to nodules. And he presented with those quite widespread to neck and upper torso. So we performed a biopsy on it, and we looked at it at our MDT meeting, and it actually was syphilis. Bacteria were actually visible in the histopathology. So we were all taken by surprise, me in particular, that I did not recognize it. This was certainly not on my differential diagnosis. I thought at a sort of chronic inflammatory condition, maybe even a lymphoma, but of all this, least I thought this was secondary syphilis. But here you go. You always learn, even if you've been doing, like myself, dermatology for 20 years.
So, you not see as many syphilis cases, I have to ask you. Is it because you didn't see as many syphilis cases as as historically?
We don't see that many. I think a lot are being managed in sexual health clinics, so they often don't come to us. We always have to have it in our differential diagnosis. A lot of skin eruptions can look very similar to secondary syphilis, so it's always worthwhile doing some blood test and checking for treponema.
That was very insightful. Thank you so much for joining me, Angelika. Don't forget that you can claim CPD credits for listening to this podcast. You just need to go to our website. I've been Sangeeta Krishnan. My guest today was Dr. Angelika Razzaque, and this episode was produced by Inga Marsden. You've been listening to the Clinical Update podcast. Do tune in next week for a studio discussion with the MIMS Learning editors. See you next time.